Hi, I'm very excited to be here today and to follow such two amazing researchers that I've actually are fangirling over right now because they're so seminal to our understanding of Alzheimer's and dementia in the field. And so today I'd like to actually, and we didn't plan this, but piggyback on some of the discussions from this morning on sleep loss and its role in Alzheimer's disease. And one of the things that's a little bit different about me versus other folks that you're going to hear today is I'm what you call a basic researcher. And so this means that we take all of these big global things we see in the human cohorts, and then we go back into our lab and we actually test different hypotheses and try and dig deep in model systems. So we use mice that actually get plaques and tangles and try and understand how all these factors that we see in humans interact. So hopefully we can help either work for therapeutic development, lifestyle interventions to understand Alzheimer's better. And so I just thought I'd begin by actually talking specifically about some of the pathology of Alzheimer's disease, because there's some ways in which Alzheimer's disease develops that as a researcher now for 15 years working in this field, I'm really struck by. So there's for the longest time, Alzheimer's disease, I think, when my grandfather succumbed to it was kind of, just synonymous with dementia. And I think over the last decade, we've come to have more of a biological definition of Alzheimer's disease. And so we all know what dementia is. We know from Dr. Barnes' talk that there's different types of dementia, but dementia of an Alzheimer's type has to have some core pathologies. So you have to have the amyloid plaques, the neurofibrillary tangles, and then some aspect of neurodegeneration. And so I don't expect anybody in the audience to be a neuropathologist. So I did a little cartoon. So pretty much in Alzheimer's disease, you have these proteins that get sticky and angry. They stick together and they cause problems. And so with amyloid, what happens is you actually get the accumulation throughout different brain regions in the extracellular space. And so you can think of this with an analogy of roads and cars. If you have cars driving down a road, the car moves perfectly fine, does its job. But if you have a Jersey barrier blocking the road or a fallen tree, as it probably was this morning, that car can't get to its destination. And so I think of the cars as the neurons and the amyloid plaques as the barriers. They can't get there. Then you have neurofibrillary tangles, which have the accumulation of this tau protein, which folds wrong, gets all super sticky, and makes neurons really unhappy. And this is actually like an insult to the car itself. So all of a sudden, the car can't drive. So now you have a road blocked, and you have a car that can't get down the road effectively. And when these two pathologies interact, you start to have a really sick brain that ultimately undergoes atrophy or degenerates. And so when we're thinking about Alzheimer's disease, you kind of have to think about these different pathologies and how they relate. And one of the other things that I'm always struck by, and I still to this day, if you have somebody who has a diabetes diagnosis, a cardiovascular insult, or cancer, normally, you have a problem that happens, and then, you get to a treatment. So Alzheimer's disease is really tricky. So that dashed line, vertical line, is really when you have symptom onset. That's when you have those cognitive complaints, those memory complaints. But what happens is a pathology has been developing for 10 or 20 years before somebody comes in and actually has an issue with remembering or finding their way around town that they've driven a million times. And so this is why the talks this morning were so important, that understanding, I'm going to be 50 next year, that right now is my time to start doing these interventions to live my best brain life, right? My best brain health. And amyloid starts first about, again, 15, 20 years before cognitive symptoms. The tau pathology, those neurofibrillary tangles, those cars get broken, and then you start to have neurodegeneration and all the cognitive symptoms. And so understanding, oops, I forgot I don't have a pointer. Understanding what's happening, what we call that pre-symptomatic phase, is something that we're really interested in knowing so that we can ward off, delay, or prevent Alzheimer's disease. And so one of the things that we've heard a lot about are these modifiable risk factors, right? As Dr. DeCarli said, we are born with some stuff, right? Like we're born with our genes. Our mom and dad gave us the luck of the draw, right? Some genes put us at risk, some genes give us resilience. And aging is the biggest risk factor for getting Alzheimer's disease. But of course, we don't want to change that because the alternative wouldn't be desirable. But then there's all these other things that we can modify. We can modify how engaged we are, how we sleep, our lifestyle, our physical activity, our food, and then comorbidities like cardiovascular disease we heard about, hypertension, diabetes, and obesity all put us at greater risk. And what's really interesting about this, and I think was highlighted beautifully this morning, is that about 45% of the dementia cases could be delayed or reduced if we targeted some of these modifiable risk factors. And I think that's really interesting to think about. So the one that I'm really interested in is sleep. You know, I'm a mom, I'm a researcher, I don't get a lot of sleep. And so I think it's really interesting when I started to get into this field, thinking about how the brain and the neurons are talking to other, how metabolism interacts with that, like this idea of sleep. And what we know from a lot of human studies is that if you have a sleep impairment or sleep loss, we heard about sleep apnea earlier, shift workers who have a flipped loss or other things, that puts you at an increased risk for Alzheimer's disease. And what we also know is that as you start to get that Alzheimer's disease pathology within your brain, even at those early stages when those plaques start to get all sticky and the tangles start to build up in your neurons, that seems to actually show in that pre-symptomatic period before cognitive decline, you start to get sleep issues. And so what my lab really wants to know is, instead of doing the scarecrow from the Wizard of Oz, some directionality, and then of course, intervention. And so why is sleep important? So we've heard that there's sleep time, but there's also, I think Dr. Carley said, sleep quality. And so sleep is super important because as you sleep, your brain actually has kind of like a pressure washer, and it clears out a bunch of toxins within your brain. And so as your brain quiets down and you're not awake, you have these clearance mechanisms that get things like A beta and tau out of your brain. It physically restores you. You know, we've heard about the vascular system is, you know, the brain is just a big bag of blood vessels that's so attached to the body. And so you need that physical restoration in order to recover from the day events. It's really important for memory formation. Actually, memory consolidation and building new memories happens when you're asleep. And then it's really important for moods, anxiety, depression, as well as fighting off infections. It's really important for your immune system. And we know when we have sleep deprivation that all these things go awry. You're more likely to get disease, you're more likely to get cancer, your mood becomes dysregulated, your brain is active in a way that's a little bit not well. And so we want to understand how this all relates back to Alzheimer's disease. And this comes back to the idea of sleep stages, so sleep time versus sleep quality. So when you go to bed at night, the best thing you can do is get consolidated sleep. They recommend 7 to 9 hours. And the whole point is for you to go through this sleep cycle. We have very light sleep, but then you get into these deeper sleep, these non-REM sleep, where you have that washing away of all the toxins of the brain. It's a really restorative process. It's really good for clearing amyloid and tau. And then you want to get into REM. And you have to kind of go through the first stages to get to the second stages. So if you shorten your sleep time, you can't get into that great REM sleep where you do a dreaming, memory consolidation, and you go through these cycles throughout the day. And so we are really interested to know, not beyond just sleep time, how do the different pathologies in the brain impact this cycle? And so what we do is we measure EEG and EMG in little mice, just as somebody would do if you went to see your neurologist. We record the same way, and we can actually see when them animals are awake, when they're asleep, what their brain activity is doing. We know high frequency activity is good for learning and memory. Lower, slow waves are good for sleep. And so we do this in our two models, and we have a mouse model that has the amyloid plaques, so that beginning pathological insult in Alzheimer's disease. Then we have other ones that get neurodegeneration and that tauopathy, that those neurofibrillary tangles. And we just simplify the system and just ask, how do these two parts of Alzheimer's disease affect sleep? And what we find is that if you look at the amyloid pathology mice, that you see an increased time in wake, meaning the animals are awake more, and it seems to selectively target that non-REM sleep, that slow wave sleep, that sleep that's really good for clearing things out. And we've looked at animals with tons and tons and tons of plaque that are super old, or animals just right when they're starting to hit the plaques, And this phenotype holds that it seems like amyloid plaques are selectively targeting non-REM slow wave restorative sleep, where tauopathy has a whole different, I guess, attack on sleep, where we see the restorative sleep of non-REM is decreased, but also REM, so that memory consolidation that we so need as we age. And so this is starting to tell us that, yes, sleep time is reduced when you have pathology, but maybe it's reduced in different ways. And we can take this one step further, and I'm not going to go through the fancy math and how to do this, but we can look at different power bands. And so this is like how the different squiggles of those EEG traces line up and what this kind of means with our understanding of the quality of that sleep. And what we find when you have amyloid plaques is that your sleep drive, your drive to go to sleep is impaired. So you don't know to go to sleep when you should go to sleep. Your slow wave sleep is decreased, so that restorative cleansing sleep's gone. And then you have indications of sleep fragmentation and insomnia. And this is a big complaint in Alzheimer's disease where you have, not consolidated sleep. And so, but that doesn't seem to be what's driven by tau, where we see this change in what's called beta activity. And this is really important for, if you think again with my car analogy, if you're actually putting your foot on the gas, those are your excitatory neurons, your brakes are in the inhibitory neurons. They have to be balanced to make a car go. And what this is showing is that once those neurons get sick, you're out of balance. And so right now we're working on ways that selectively targets these changes to see if we can get a better therapeutic for restoring sleep. And so just to summarize, plaques and tangles, bad for sleep. We should do everything we can to promote sleep. It's very good. Good sleep hygiene is very important. But we think that amyloid and tau are impacting sleep in a different way. Thank you.